So let's welcome Will Shrank to the podium, who's going to talk about improving patient engagement.
Well, thanks so much for having me. I would like to open with two quick disclaimers. One is that I now work for CMS, for the Center of Medicare and Medicaid Innovation, and these comments reflect my own views and not the views of the agency or the department. My other disclaimer is that I have two children under the age of 4, and I believe that I have one of the nation's longest streaks of viral illness. So if you do hear me breaking into some sort of bizarre coughing fit, I will recover, but I apologize in advance. I want to talk to you today about a problem that you're all familiar with and seems like it's something that should be relatively easy to fix, but it's not. And I want to talk to you a little bit about why it's not, how important it is that we fix it, how the scientific, the business, and the policy worlds are all coming together to help us deliver solutions to improve this problem, and walk out of here with a little more of a strategy about how we all can work together. So medication non-adherence is a massive public health concern. On average, patients only take about half the medications that are prescribed for them, even for really important chronic diseases like diabetes, heart disease, coronary artery disease, congestive heart failure. And the implications when patients don't adhere to their chronic medications are substantial. It leads to massive amounts of unnecessary hospitalizations, unnecessary heart attacks, unnecessary adverse events, and real costs. The costs on an annual basis in this country that have been attributed to medication non-adherence have ranged, but generally fall in the range of $150 to $290 billion a year. And to add some context to that number, during our president's current term, it would mean that somewhere between $500 and well over $1 trillion are being wasted because our patients are not adhering to evidence-based, oftentimes generic, low-cost therapy in the management of chronic disease. And frankly, the problem may be worse than we ever knew. Historically, when we've come up with estimates of non-adherence, we've used pharmacy claims. We've looked at when patients have begun a medication, and then we look at the frequency at which they refill. But with the onset of electronic prescribing, we have a whole new source of information. We know what doctors write, in addition to what patients fill. And by looking at that gap, what's written but never filled, we get another inkling of the patterns of medication use, and a disappointing one in which, on average, when new prescriptions are written, even for important chronic diseases like cardiovascular disease or neurologic disease, between 20 and 25% of those first prescriptions are never filled. So even the problem of medication non-adherence is even greater than we had thought. And to make matters worse, patients who bring their prescriptions to the pharmacy, they actually deliver it to the pharmacy, not infrequently abandon them. And the biggest explanation is cost. So on average, about a little over 3% of prescriptions are abandoned. But when patients bring a prescription to a pharmacy with a copay of $50 or more, which is not an atypical copay in today's 3-tiered benefit system, it's about an 8% rate that patients walk away and they experience sticker shock, and they choose not to purchase the prescription. This has all kinds of costs for patients. It also has costs in terms of efficiency for pharmacies who have to go through the process of filling and unfilling medication bottles that's been estimated at about $1 billion a year. And maybe it's not so surprising when we consider the massive complexity that patients face when trying to manage multiple chronic diseases. On average, a new patient that started on a statin, on a cholesterol medication, takes 11 other medications, 9 of which are maintenance medications. They make 5 visits to the pharmacy in a 3-month period, and only half of their refills are synchronized. So they have to go on multiple occasions to pick up their medications. If you look at the 10% of the most complicated patients, you'll find that they take 23 or more unique medications in a 3-month period. They make 11 or more visits to the pharmacy and to 2 or more pharmacies over a 3-month period. Only 10% of the refills are synchronized. So they're virtually going every single day to the pharmacy, and those prescriptions are being written by 4 or more prescribers. So it's not surprising the patients with chronic disease are having a hard time managing this multitude of medications. And when you look at predictors of non-adherence, some of these characteristics of the distribution of the medication come out loud and clear. Using more pharmacies is associated with worse adherence. And being able to synchronize prescriptions on the same day rather than going multiple days to pharmacies to pick up prescriptions, synchronization is associated with a substantial improvement in medication adherence. So, there's been a lot of discussion over the years about what we can do to improve the way patients adhere to their drugs. And sadly, there haven't been any home runs. There's been a handful of studies that show modest improvements in adherence, but we haven't had those home runs. And one of the key reasons is that medication adherence is a very complicated, complex behavior. There are a host of reasons that patients don't take their medications at a number of different levels. So patients don't take medications for a number of reasons that range from their understanding, their cultural beliefs, their psychiatric or illness, their cognitive limitations, their ability to afford the medications, the complexity of the medications, the side effects. Excuse me. Physicians essentially never know. Physicians never know if their patients are actually taking their medications. Physicians are not provided with the data they need to know if patients are actually taking their medications. So there's a big guessing game there. And the system is highly fragmented, and there's a number of ways in which barriers, either administrative, financial, are placed between the patient and the medication that they need. So we're learning more about what works and what doesn't work in terms of developing and implementing interventions to help patients adhere to their medications. We don't have best practices yet, but we're heading in the right direction. One thing we know is multifactorial interventions are far more effective than simple ones. Simple interventions with just either an education or a mailing is extremely ineffective, but multifactorial behavioral interventions in which we're able to engage patients on more of those possible explanations or barriers to adherence tend to be more effective. Physicians, in the studies that have been done, are not particularly effective at delivering interventions to improve adherence. Whether it's because they don't have the data, they don't have the time, or they don't have the inclination is not clear. But in the studies that have been done to date, physicians have not shown that that have not been extremely successful in that role. On the other hand, pharmacists have. Pharmacists are a trusted partner and have been shown to play consistently a substantial role in improving the way their patients use their medication, particularly when interventions are delivered at the point of dispensing in a face-to-face interaction. There's more and more data about the use of health information technology to improve adherence, and simple electronic reminders consistently work. The effect size is relatively small, but they're extremely inexpensive, and they do consistently work. And we're learning that the most effective interventions are the ones that build off the database that we have to learn who's at the greatest risk of non-adherence, who just fell off the wagon and who just became non-adherent, and really targeting our interventions and our strongest interventions to the patients that we know are either at risk or have just failed to use. But that was sort of the glass is half empty. We don't know a whole heck of a lot. The next part is the glass is half full. We are in the process of learning extraordinary amounts about what we can do to encourage and change the way patients use their medication by supporting them better. First, the emergence of health information technology will change the way we support our patients. There's been, as we all know, with changing incentives, has been and will continue to be explosive growth in the use of electronic medical record systems, which includes e-prescribing, and we will now be able to identify in real time patients who fail to adhere and be able to intervene directly upon those. We'll be able to find patients who fail to initiate a new prescription and intervene directly on those patients. We'll be able to communicate with providers and pharmacists to close the loop and create the right kind of team that we need to better communicate with patients and encourage them to use their medications. We'll be able to do a better job of linking pharmacy and medical claims together to do more prediction, to better have an understanding of risk stratification and the kinds of interventions that may be most effective for a particular patient. And we can certainly start delivering extremely inexpensive, automatic, electronic reminders, texts, phone calls to patients to try to remind them when it's either time to take their medications or refill their medications. And I think you can easily imagine a future in which we're better using our data, the data that exists, to create a system to encourage all the healthcare system to participate and to communicate better with our patients about how they take their medicine. There's also a growing evidence base around how we structure our benefit design. There's been an interest in this whole idea of value-based insurance design and reducing co-payments for the medications that we think are most cost-effective. There are a couple observational studies in the field that have some limitations, but the definitive study will be published later next month. We randomized 6,000 patients who had new heart attacks to either usual care or to get all their heart medicines for free. We worked with Aetna, and we made the argument to Aetna that if patients get those medicines for free and even have a small bump in their adherence, we'll reduce subsequent heart attacks, and those subsequent heart attacks are a lot more expensive than the copays that they're being asked to pay. And as such, by giving away those medications for free, you can save lives and save money. That trial is complete, and those results will be available soon. But this kind of evidence, this kind of literature, will help us ultimately to build the kinds of benefit designs that are going to best align our incentives with the kinds of behavior and the kinds of activity in our patients that we want to see. But it may not be that just removing barriers is the best way to encourage the behavior that you want to model. If any of you are parents, you've probably tried a number of things to change your children's behavior. And I bet you the most effective strategy was not just to remove barriers, but you might have used a carrot. You probably don't like to say it out loud. Maybe used a stick every now and then. But using real incentives that a child or that a patient feels can be a far more potent way to model the behavior that you want to see. And increasingly, we're seeing studies in the field to test these kinds of approaches. The federal government recently funded over $100 million for 10 states and Medicaid to develop broad, incentive-based approaches to promote healthier behavior, and a bunch of private companies are now experimenting with new strategies to use rewards and or potentially punishments for patients who do or do not adhere to their medication. So in the future, we're working towards a benefit design that will be evidence-based, that will get the most out of the investment that we make to optimize the way patients use their medication. And I'm particularly excited about this idea of social networking. We know that when patients have important relationships with family or friends who participate in their medication taken, excuse me, they are more adherent to chronic medication therapy. So when family or friends either offer emotional support, offer instrumental support to help remind them to take the medications, or both, patients adhere better. And the fact that we aren't doing a better job of utilizing and engaging and formally requesting support from family members, this is a free resource for us if we're able to do it, to try to get folks that care about the patient to improve their medication use, I think is a huge opportunity. But even, maybe even a more interesting and cool opportunity is the fact that more and more patients are going onto the web, onto social networking sites, and meeting up with folks with symptoms and conditions just like theirs. They're going to diabetes sites to learn about diabetes and their medications and the side effects and the symptoms that they're experiencing. They're doing this in droves. There are millions of patients out there, meeting up with other folks like them. And we did a qualitative evaluation of sites on Facebook that are focused on diabetes and found really, really some beautiful things. Patients are sharing very personal stories about their own trials, their own tribulations, their fears. There's a huge amount of support, a huge amount of community building, and a wonderful opportunity to learn from each other and to support each other and to encourage each other to do the right thing. On the other hand, there is a not insignificant amount of promotional activity, and there's a huge amount of variability in the way these sites are structured and the way the oversight is presented. So I think that this is a process that's in flux and that is certainly bound to get better. But if we can learn better how to harness the power and the enthusiasm and the community that is created on social networks, I think we could go a long way in supporting and improving the way patients adhere to their medications. So enter the Innovation Center. I'm not sure how familiar everyone is about the Innovation Center. It was funded by the Health Reform Bill. The purpose of the center is to test innovative payment and service delivery models to reduce program expenditures under Medicare, Medicaid, and CHIP while preserving or enhancing the quality of care furnished. We preference models that improve coordination, quality, and efficiency of healthcare services. So in other words, we fund new payment models that have the potential to reduce the overall cost of healthcare and that will be quality neutral or better. Those are the kinds of interventions that we fund. We have $10 billion appropriated between now and 2019, and the coolest thing about the Innovation Center is if we test something, and I lead the evaluation group, and if the evaluation group demonstrates that it saves money and is quality neutral or better, and we can certify that with our actuaries, it does not need to go through the rulemaking process. The secretary can make it national policy the next day. And with the presence, with the implementation of the Innovation Center, we're seeing a massive change in incentives in how we pay for care in the U.S. Excuse me. I'm sure you're all aware of ACOs, and you're likely aware of the new Comprehensive Primary Care Initiative and the bundled payments for care, which are largely trying to figure out how we can pay for care that is more coordinated, that supports, that reimburses better value and more cost-effective care rather than greater volume. All of these and the Partnership for Patients, which focuses on transitions of care, all of these initiatives, every one of these initiatives focus on improving the management of patients with chronic disease. And if patients with chronic disease, you can give them all the care coordination in the world. If patients with chronic disease go home and do not take their medication, they will be back in the hospital next week. So there is an opportunity here. All the incentives are aligned to keep patients out of the hospital, to improve the quality of care, but there's a gap. There's an opportunity for folks who have innovative ideas, who can be partners, who can work with providers, who can work with ACOs, who can work with primary care, patient-centered medical home primary care settings, that can work with hospitals and post-acute care settings that manage patients who are hospitalized for surgical procedures. There is a very important opportunity to intervene, to collaborate, and to build teams to better improve the way patients use their medication. And this is one of these unique opportunities in life where everyone's interests are aligned. I challenge you to think of other opportunities like this. Pharmaceutical manufacturers, health insurers, PBMs, pharmacies, employers, patients, doctors, everybody wants their patients to adhere better to their medications. Hospitals probably don't because, with better adherence, there's less hospitalizations, but I don't expect that hospitalizations will be picketing the streets, arguing for worse adherence. The reality is this is one of these very unique times and a very unique opportunity. And the fact that all these key players are aligned offers truly a once-in-a-lifetime opportunity for collaboration. So I really think the timing is right to act. We have a new business context that provides the kind of incentives that we need to support new kinds of collaboration. We have a business environment in which everyone's interests are aligned. And, frankly, we live in a world where we need to figure out solutions to reduce the overall cost of healthcare. And if we don't, the way those solutions are going to be bestowed upon us will probably be far less appealing to us. So this is our chance. This is our chance to collaborate, to work together across lines, to think about how we can partner, use better technology, use better evidence in pharmacy benefit design, use new technology in social networking, garner the power of families to try to better encourage patients to take their medications as prescribed. And, this may be a bit of an overstatement. The picture may be a bit of an overstatement, but I'm hopeful that when we look back on medication adherence in 10 years or 15 years, we'll think a little bit about it as we do about the rotary phone, that there was a time where we had this completely fragmented, uncoordinated system where data was not being used appropriately. We did not have good evidence to create our benefit designs. We were not creating the kinds of interdigitations and coordination in care that are needed to support better adherence. And we will be very thankful that a sea change has happened and that we have gone a better way. So with that, I'll answer questions.
Because we started a bit early, we do have time for some questions, if there are any from the audience for Dr. Shrank.
Thank you very much. My name is Jean Moses. I work for Partners Healthcare, and no, we will not lobby against adherence. But you suggested the issues on the internet with various social networking sites, et cetera, and the inconsistency of maybe the quality of data. Have you any ideas as to how you think that will improve? Are we talking government regulation of internet sites?
So I'm certain that government regulation would be the wrong way to go. I think what's special about social networking sites is that those are places where patients select to go to find people like them. And I think that as soon as there's government regulation, they'll be far less appealing for patients as a site, as a place to hang out and meet other people. I believe that the best way to do this is to have educated patients create a system, a network of more like eBay, where you kind of judge and evaluate everyone else on in the network, and you give a 3-star rating to somebody who gives a really useful piece of information about diabetes medication. And if somebody looks like they're selling some green juice that they promise will fix your diabetes, you give them some kind of a black ball, or I don't know, some kind of way of saying that that person's not a productive member of the group. My sense is that in health, the way in which patients evaluate and interact with and judge each other hasn't matured as quickly as we've seen in like CNET and technology or in other areas of internet commerce. And my hope is that it does. And it would be great if we could somehow use some evidence to help patients build those programs so that they will be as effective as possible.
David?
Thank you. Bill, I wonder if we've looked so much at the technology of messaging people, we haven't looked enough at the behavioral psychology that motivates people. And B.F. Skinner was one of my teachers. I always try to channel him. One of the issues is there's a big difference between messaging or alarming a person. Alarm, the word, means something's unpleasant, something jangled, I may have been asleep, and something's now telling me get up and take your medicine. What Skinner was much more open to was a signal, a nice song or whatever from your phone that says this is the beginning of a window to take your medicine, and then very rapid reinforcement after the dose has been taken. Have you looked into that, just the timing and the way we can interact with behavior to promote adherence?
Well, thank you. That's a really astute question. In fact, I think Joe might have more insight into this than me. I do know that there's a host of technology companies out there that are thinking about that are building businesses around messaging patients to help them improve their medication taken. And I am certain, and I know that they're thinking not just about yes, no, do we send a message, but what does that message look like? What's the best way to engage someone? What's the best way to, sort of model the behavior? So I think you're asking just the right question. I don't think we have the answers yet, and I don't know, maybe Joe could speak to this and give more insight.
Well, my quick comment on that, David, is that in the beginning, when you have a completely unmanaged and chaotic systems, little things can make a big difference. So these days, if we send patients a text message reminding them to take their medicine, we'll see a bump in adherence. But you're quite right that that's not a long-term sustainable solution. It just reflects that our current system is chaotic. And we need to be much more mindful of the kinds of solutions you're indicating going forward so that we won't get the decay in signals after people get sick and tired of hearing the alarm, which we all know exists as well.
Could I follow up with a second question that I think is very important? It's medication reconciliation and what happens in a hospital after someone with congestive heart failure has had his medicines readjusted. What happens when he goes out? It's my view, as Joe knows very well, that there's a lot of confusion about which meds to take, what doses, and that's why my own approach has been a machine that looks at pills, so we're sure the medication adjustment's been made better. But I wonder if there's a more fundamental possibility of making the distribution of medication in the hospital more like the distribution of medication outside. Again, I want to make this brief, but I was in Beijing recently, and their hospitals do not use the standard carts made by Pyxis and others to distribute medicines. So the idea of a medication monitor that would be filled in a pharmacy robotically or by humans, a tray that would go up to a machine next to the patient, and a machine that would go out, the identical machine actually, to a patient outside the hospital and use 3G or 4G technology. Do you think we can do something like that to make the reconciliation problem less? Because we give out the medicines in a hospital a very different way from the way we ask people to stay on medicines at home.
Well, the short answer is I know we can do better. This is a point in care where we know that the handoffs don't happen as well as they should. One of the reasons that the government invested $1 billion on the Partnership for Patients was to spend half of that on improving transitions of care when patients leave hospitals. You're asking, so you're posing, you're making a statement which I agree with wholeheartedly, that this is a big problem. The question that you ask is kind of a harder one. I don't think we really know what works best. How much of this should be automated or could be automated? Maybe a lot, and maybe that would be by far the best solution. It may be also that for elderly patients, they want that sort of human touch, and if we do have the capacity and if we do have the wherewithal to send a community, a relatively low-cost community health worker out to somebody's house to make sure that they're taking their medications, to see where they're being stored, to make sure that they can differentiate between the different bottles, that they can open the bottles, that they're, there's an argument that can be made for the person as well, and I'm not aware of good, prospective, randomized, controlled, head-to-head trials of these different kinds of interventions. But these kinds of interventions are really important. They're really important because they're going to tell us more about what works, and they're going to also tell us more about the cost effectiveness of these different relative interventions. And these are the kinds of ways that we're going to have to make these decisions in the next 6-8 months. The time is now. If we're going to implement these things, we're going to have to do it now, and we need these kinds of answers as soon as we can. So I appreciate the question, and I think you're right on.
Thanks very much, Will.